So it was really excellent panel discussion. So many carry home messages are there. Please, so let us all try to do all our best. So going forward, the next session is a small presentation by Dr. Jai Desai on the scope of fetal medicine in our practice. So Dr. Jai Desai, may I call upon Dr. Jai Desai? So Dr. Jai Desai, who is obstetrician and gynecologist, he did his MBBS from the Vadodara. He did his DGO and DNB from Mumbai. He has got postdoctoral fellowship in fetal medicine from Kerala. He is the junior consultant in fetal medicine at Trichy, consultant in fetal medicine at India IVF Hospital Private Limited in Rajasthan. He is consultant in the maternal fetal medicine and genetics SOUL at NAVSARI. His expertise is in ultrasound 2D, 3D and the 4D scans, prenatal diagnostic procedures, fetal therapy and genetic counseling. He has got so many awards and accomplishments. He has published so many papers in the journals. One is like classic corners of the Lens syndrome with a variant of unknown significant detected in anti-Bibel group report. That is an Egyptian journal. He has got the certificate for the first rank in the evaluation examination in the master class of the Ops and Gynec ultrasound. He has got the certificate for even 11 and 13 week scan, NT scans, nasal bone scans and the Doppler ultrasound in the cervical assessment. He is IOTA certified for assessment of adnexal masses. So he is, I can say, the expertism in the scan and the prenatal diagnosis of the fetal. So welcome Dr. Jai. Hope he'll be ready with his presentation.
So, warm good afternoon to all. After a marathon session about the do's and don'ts of anesthesia and obstetrician, I think everyone is settled up in their mind who is the winner, because we need to work as a team. So, I bring greetings from Soul, Shades of Into Life, Fitomental Wellness Clinic, M-Fine Diagnostics and LifeCell. I would like to just throw us a few light upon the scope of fetal medicine, seeing what is the present, the past, the present and the future of fetal medicine in our field. So the whole world of fetal medicine, the whole science of fetal medicine is based on Galileo's one statement, which says that measure what is measurable and make measurable what is not so. So in the past, whatever things were not measurable, those things have been made measurable in the present. And field is so developing in the recent years that many more things which are not measurable as of now will be measurable in the upcoming future. So just to brief what is the scope of fetal medicine in the current scenario, I would just like to introduce the Hears Index. Now this shows the impact of a particular scientist rather than a journal. So for example, if a scientist A has published H articles, publications, he has H number of citations. So the father of fetal medicine, who is known as Kypros Nicolaides, his H index is 185, which is the highest amongst all obstetricians in the world, which is even more than Stephen Hawking's, which had a H index of 110, and Einstein, we had an index of 119. So all the news which we all want to hear is that your patient is pregnant, everything is fine, everything is going to be normal. That is what all we want to hear from ourselves and from the patients also. Be it a low risk pregnancy or be it a high risk pregnancy, the obstetrician and the mother would do anything to provide unnatural care for the baby growing inside the womb. But the news which you don't want to hear are the birth defects, maybe structural, functional or metabolic, which are a leading cause of infant mortality rate in this scenario. And they account to be around, they are occurring in around 2 to 5% of all pregnancies, and congenital anomalies are one of the important causes of perinatal mortality rate as well. So what could be the major causes which we come across? They are like congenital heart defects, NTDs, Down syndrome, hemoglobinopathies like thalassemia, sickle cell, which is more common in our belt. They are a cause of 20% of infant mortality rate. And mind you, 70% of these defects can be easily preventable by the cost of various cost-effective genetic services. Now, out of these deformities, how are they classified? Some of could be the malformation, where an intrinsic problem is already there, which we see when the baby is scanned, like there is an spina bifida, or there is an or there is an omphalocele, or this could be a deformation, where the baby was genetically born to be normal, but due to some external forces, this baby has developed certain problems. They could be like limb contractures that develop due to oligohydramniosis due to renal agenesis. Or they could be disruption when there is even severe worsening of the external forces that causes the severe damage, like damage from amniotic band, which cause limb reduction defects. Or they could be some syndromes where there is definitely some genetic issue in the baby that has led to a cluster of events that has occurred, like trisomy 21, 18, or 13. Or they could be a sequence, like anomalies that are developed sequentially because of one insult, like the Pierre-Robin sequence, where due to micrognathia, there is glossoptosis and that leads to cleft palate. Or there could be some associations where they cannot be linked etiologically, but they tend to occur in a group, like the vectoral association, where we see vertebral, anal, cardiovascular, tracheofacial, esophageal, renal, and limb defects occurring together. So this is just a pictorial manipulation of the same. But why do we need to worry for them? Why do they occur? Because it is written, or there must be some defect in the central dogma. That is, the 23 pair of chromosomes which we get from our parents, or in the DNA, or the 80 GC pairs, which are around 3 to 2 billion bases in the DNA, accounting for 20 to 25,000 genes. Now, when I unwind myself from a body organ to cell chromosomes, this is how it might look. And there they code for proteins, where they code for proteins which are responsible for various cellular functions. When there is an issue in these proteins, they will lead to abnormal cellular functions. So they may lead to some chromosomal disorders, or they could lead to some genetic disorders. Now, what all could be they constitute around chromosomal? There could be single gene disorders, multifactorial, unknown, or due to some prenatal exposure. Now, amongst the chromosomal disorders, majorly is trisomy 21, which consists around 53%. Rest are minor contributors. But why do we need to worry for trisomy 21 at such a large scale? Because it is one of the most common cause of intellectual disability and commonest chromosomal abnormality noted in live births, with a ratio of occurrence of prevalence of 1:700 to 1,000. But mind you, this is not the commonest chromosomal aberrations which we see. The most commonest is trisomy 16, which leads to early missed abortions. Now, seeing all these things, why do we need to worry for all these things? Because this is the need of the hour. Because India is the second most populous country in the world, where ladies are delaying the conception. The mental age of conception is getting delayed. There is increasing proportion of unplanned pregnancies. The antenatal coverage in certain remote areas is not proper. Even the medical conditions of the mother have not been recognized many times. The rate of consanguineous marriage has been increased. Even the career status of the couples have not been screened before marriages. Even the nutritional status may not be good. As I said, the age is increasing day by day. So whenever the age is up to 24, 35, the risk of chromosomal abnormalities is not great. But once the age is crossing above 35, there is a four-fold increase in the risk of trisomies, and there is a tenfold increase after the age of 40. The Turners and the triploidies do not have a high risk. They're independent of the age factors. Now, we have just seen what is the issue. Let's focus on certain numbers. The number of chromosomal abnormalities are 1 into 200, microdeletions are 1 per 1,000, and annually around 1.3 million babies are born with these defects. 7.9 million babies are born every year with the defect. And in India, it constitutes around 6 to 7% of this. Seeing the various data which have seen, anencephaly and typhus equilovirus are the most common congenital anomalies recorded on scan, which could be easily prevented by just a folate supplementation in the periconceptual period. And the talibus is an easily correctable surgical condition. When we come down to Gujarat, our multidisciplinary study at the Kutch district showed that the mean age was 22.3, of which 70% was primary gravidas, and hydrocephalus being the most common cause anomaly detected, with 60% having consanguineous marriage. Even a famous article by our famous pediatric cardiologist in Surat, Dr. Ritesh Sukramwala, has said that nearly 700 babies are born every year with heart defects in the city. So this shows utmost importance of proper scanning, how we should do offer to all our antenatal patients. It is not possible by one person. As we learn in the morning, since morning we are seeing, we can do it, but we need to do as a team. So how can we do it? With the help of government, we can do certain studies could be built up, like iodization, fortification of salt, proper care, periconceptual care, screenings should be done. But even after doing all these things, still the patients will have a lot of questions in their minds whenever there is a high-risk pregnancy. So in such cases, where the people step in are the maternal fetal medicine specialists, where they take utmost care of the babies. For them, the baby of the mother is the patient. So they are people who have advanced knowledge and training in medical, surgical and obstetrics complications of pregnancy. So this is what they mean. What do they have to offer? Well, as we said, mothers can be forgotten. They are always the priority, even than the baby. Offer proper screening at the right time and give the proper choices. We are here, the fetal medicine specialists are here to declare the normal in majority of cases. As we saw earlier, abnormality account for only 3%, but 95 to 97% babies are normal. So the fetal medicine specialists are here to declare the normal. Also, if some abnormality is detected, correct diagnosis, what tests should be offered, and faster solutions should be done. So what is screening? Why are we emphasizing so much on screening? Why is the whole world of fetal medicine developed on this concept of screening? So screening is given to the whole population to identify those people at risk for a condition amongst all the asymptomatic people. So seeing from the image where all population is screened out, the high-risk people are known and they are advised further treatments. So how did this idea of screening develop? So let's rewind a bit. Let's go back in some time. So in 1960s, the screening was only based on maternal age. Then came in the fetal ultrasound. Then came in the AF, that is alpha fetoproteins. Then in 1980s came the group of AFP and beta HCG. Then the Benacerraf group found out the nuchal fold thickness. Then the NTs. Then the FTS and NTs by the Nicolaides, the father of fetal medicine. And then came the FTS with these markers. And lastly, we had the NIPT in 2011. So the screening has undergone an evolution, and we have revolutionized this science. Like just with evolution, we underwent an evolution. So starting from maternal age to biochemical screening, now all the way we have reached till exome sequencing, on which further details will be shared by the next speaker. So what all tests can we offer to the patients are the karyotypes, the microarray, and the gene sequencing. So just in the way we have advanced in the field of serum screening, even in US is also very advanced. So the first image which I am showing here, this is the normal NT which Nicolaides had taken in 1992. After which, this was the chart they developed in 2002. Then came in the DNA, cell-free DNA, and right now in 2023, the updated guidelines by the FMF show this beautiful picture where proper magnification with proper calipers placement, mid-sagittal section where the IT is seen, where the midbrain is seen. All these criteria should be seen so that a proper NT is taken. NB is seen where the proper nasal bone can be seen. Then the DV is recognized. The TR, the tricuspid regurgitation, is also seen with proper magnification. So USOC came up recently. USOC has updated the guidelines in 2023 of what all proper things should be seen in an NT scan. So from marking of CRL, proper measurements, NT, DVTR with uterine measurements should be taken. And this is just a pictorial representation of what all anomalies or what all images should be seen at least in the NT scan, so that should be documented properly. Certain things should never be missed at an NT scan, which could be like acrania, anencephaly, body stroke anomalies, exomphalos, gastrochassis. And like ventriculomegaly or telepathic virus, VST, ball atresia, they are likely to be missed at anomaly at NT scan, which needs proper follow-up. So concluding in this, the aneuploidy screening, we have a cutoff risk of 1:250, where we have a high risk. 150 to 1,000 is intermediate risk, and anything above 1,000 is considered as low risk, where we don't need to do anything else. But all this should be performed with FMF according guidelines, where the platform should be Adelphia, Roche or Cryptor, where the obstetrician should emphasize the labs wherever they send the sample, that they should be rubbed upon this platform, and the reporting models should be on LifeCycle, Astrea and Viewpoint, and not on the Prisca software, which the routine labs are offering at present. So this is just a report of an enhanced FTS, which is a new kid in the block, where we see 4 markers like the AFP, HCG, PAPE, PLGF, where we screen not only for the trisomies aneuploidy screening, but we also screen out the risk of preeclampsia in the mother. But why am I speaking so much of this of screening? Is it really a necessity? So let's check out few myths and facts. So one of the myths is Down syndrome is very rare. But as I showed in the previous data, Down syndrome is common in 100 fetuses are affected. 26 million babies of Down syndrome are born annually, of which 26,000 cases per annum. So this is quite a large number. Myth 2 is Down syndrome can be picked by scans, which is very wrong. In 40 to 50% of cases, Down syndrome babies will have normal ultrasound till the end. So we cannot completely rely only on scans. Families cope up well if they have a baby with Down syndrome. It is absolutely false. It has a huge, tremendous impact on the family as well as society, which is totally immeasurable. This is a recent public article where the Supreme Court rejected an female abort a 26-week-old baby which was having Down syndrome because there was no danger to the life of the mother. No medical legal liability? Absolutely no. Be prepared for the worst, because this is a recent article where a baby was born of Down syndrome, and the couple had filed a case in the court concerning of alleging medical negligence of the obstetrician. Down syndrome affects only aged mothers. Yes, the risk increases with the age. I don't deny that. But the number of patients which we get in this life are more in the ages of below 30s. So we must offer screening to all the patients. What does professional organized body say? Be it NICE guidelines, be it RCOG or ACOG or the Society of Fetal Medicine India, the SFM guidelines, even the FMF all say universal screening is must and should be offered to all ladies to know their chromosomal risk of their fetus. Now, if we miss out something in first trimester, in second trimester, what we can offer is a genetic sonogram where we look out for the 7 markers which have been studied in the details in the literature. We can offer the quadruple marker or the NIPT. If a soft marker is present, it has a higher incidence in the aneuploid fetus than the euploid fetus, but it is still a variant of normal. We do not constitute this as a structural defect. Presence of a marker does increase the risk of abnormality, but does not confirm it. And absence of a marker decreases the risk of chromosomal abnormality, but does not rule it out. And please, second trimester triple marker test should not be offered. It's an obsolete test. Please don't offer this test to any of your patients as of now, because the sensitivity and the false positive rate are very low, and we have much better tests than this. So they are like second trimester quadruple test, where we see in the 4 markers where you can analyze and give a higher sensitivity, that is around 80 to 84% detection rate. Or we can offer non-invasive prenatal screening, where all the 5 chromosomes along with all the 22 other chromosomes can be screened out. After this, the role of fetal medicine also is extended in the second trimester, where we do proper ultrasound, taking proper measurements, ruling out all the anomalies starting from the head to toe, the ventricles, the arms, the cerebellum, the nose, lips, the chin, the eyes, the situs of the baby, the kidneys, everything has to be seen and properly documented. So USOC has come upon with a proper guidelines and proper charts which we can see and just provide checklist so that we have seen everything and we have documented each and every fetal body part or not. Same thing goes, updated guidelines in 2023 by USOC for cardiac screening says that fetal echo should be offered like a screening test, a universal screening should be offered to all patients, be it in the second trimester or be it in the first trimester. It should be done within proper steps by all and offered to all the patients. Now the role of ultrasound in screening and for preeclampsia. We should act early so that we can screen early. And only PI index of uterine artery is must, which should be used for screening. Be it first, second or third trimester, mean uterine artery PIs should be considered for screening with metal factors, arterial blood pressure, uterine Doppler, and PLGF level. As I said, the first trimester quad test, which is the best way, which offers around 95% detection rate. Now, the role of ultrasound in the prediction of preterm birth, these are the proper guidelines, how a proper cervical length assessment should be done. Those are the guidelines measured where a proper 70 to 75% magnification with a proper screening where we can see both the lobes of cervix equally without any external pressure should be seen. So that we see certain beautiful images, like the first image which we see up is of a normal cervix. If normal pressure if not exerted, then undue pressure, then we see unequivocal lips of the cervix and funneling is masked and we can easily miss upon a preterm labor. So the cutoff guideline which we are screened by the USOC says that 2.5 centimeters or 25 millimeters is considered. For if a patient if a primary comes up with no previous history of a preterm labor, if the less than 25 millimeters, do consider vaginal progesterones every 1 to 2 weeks till 36 weeks, or if it is less, when the measurement goes than 10 weeks, consider for cerclage. Or if any patients come for his history of preterm labor at 14 to 27 weeks in the previously, we can offer a transvaginal cervical length assessment at 14 weeks and accordingly we can manage. Or if a patient has a history of preterm labor in 28 to 36 weeks, we can start screening from 16 weeks onwards and accordingly we can manage with transvaginal progesterones and cerclage when it is less than 10 millimeters. So, scope of fetal medicine is endless. Still, they have proper guidelines for the assessment of fetal biometry and growth, management of FGRs and small for gestational age, even in congenital infection. The Doppler velocimetry which should be taken in proper way, so that we can document it in the proper manner. How a twins should be managed, whether it's a DCDA pregnancy or it is a monochorionic pregnancy. Invasive procedures for prenatal diagnosis, fetal CNS systems, role of 3D, 4D in ultrasound, and even MRIs have been developed lately. This is the upcoming future of fetal medicine with intrapartum ultrasound. Even in therapies, we have multiple fetal pregnancy reduction, blood transfusion, RFAs, shunt procedures, and fetoscopic laser procedures. Ophthalmic artery evaluation is the new kit and is one of the future which will be used to predict preeclampsia, which can be offered at second trimester by measuring the peak systolic velocities and seeing the PSV ratios. Artificial intelligence has also gained into fetal medicine, where an app sees the various physiological parameters seen on the screen with proper quality, productivity, and security, which helps to detect around 294 syndromes, and we can offer proper care to the patients. Even the cell-free DNA, the people are working upon to look for prediction of cancers from the cell-free DNA reports. So this is the future, and the scope of fetal medicine is endless. This is the endless list which I am showing you from one of the recent published articles. So a fetal medicine center is like a one-stop solution of care where you will answer all the questions like what does this abnormality mean, what can we do, whom do we talk to, where do we go, what is the prognosis. But it's not possible alone. We have to work as a team. So the maternal fetal medicine specialist, the anesthesiologist, the nurse, the geneticist, the neurologist, all work in a team, because no one specialist can take sole responsibility for the treatment of a mother and a fetus in such complex conditions. So let's offer optimum antenatal care to the patients by giving first trimester screening to our patients so that we have a proper prenatal diagnosis and we can protect your unborn fetus. Because the new science of fetal origin believes that the first 9 months before birth shape our rest of the lives. So smile, wave, blink and yawn, which many of you must be doing. We can share those precious moments with you and show it to your baby. In spite of all this, I still say that what we know is a drop, but what we don't know is an ocean. Thank you for patient listening.
Thank you, Dr. Jay. Talking about from evolution to revolution. Hope we can do now fetal surgeries also in utero. That yes. So I would like to call upon.
Now there is another presentation by Dr. Gaurav Shastri on selection of proper genetic test. Request him to come forward. But before that, 5 minutes, a prize winning time for us. Unison people. Dr. Styen, please. Unison people are here to declare the winner of the draw they had conducted. Dr. Jay. Dr. Jay, please come. Request Dr. Dipti-ben Mehta to felicitate Dr. Jay Desai. First prize? Third prize. Number 460. Third prize goes to number 460. Is the winner around? Third prize. No? Another surprise? Second now. Second prize. No. 459. 458. 458, yes. Second prize. What is the second prize? શું છે? એવું છે? થર્ડ પ્રાઇઝ વાળા નથી કોઈ? થર્ડ પ્રાઇઝનો નંબર કયો છે? 460. તો 59 તો 58 આવશે. Now I hope first prize is mine. I hope. Or at least my wife's. 461. Anybody around with number 461?
464 છે.
Nah. 461. તો નહીં ચૂકી ગયા તમે. બીજું કાઢી દો.
હવે નથી આવે તો બીજા કાઢો. હવે નથી આવે તો બીજા કાઢો. બીજું ફિનિશ.
ત્રણ જ છે ને પ્રાઇઝ?
જેટલા છે એને લાભ મળવો છે. હા, જે નથી તેને
they will ask in the future. નથી આવ્યા એટલે પણ માંગશે.
Thank you for all this. Dr. Gaurav Shastri, he's here for his topic, selection of proper genetic test. Dr. Gaurav Shastri is a consulting geneticist with experience of more than 12 years. He obtained his PhD from the South Gujarat University in 2007. And he obtained a fellowship in reproductive genetics in 2011 from Mumbai and Ahmedabad. He has got more experience, so I can say about 12 years. So his key areas of interest in genetic counseling, reproductive genetics, prenatal genetic diagnosis, pre-implantation genetic diagnosis, cancer genetics, and genomics. Just now he is working as a director of genetics genomics. Maybe there's a part of Sterling?
Yes.
In Surat?
Yeah.
Yes. So here is Dr. Gaurav Shastri. Yes, doctor.
Thank you, ma'am, for a wonderful introduction. Thank Styen Gajjer sir for inviting and giving me an opportunity to be a part of this wonderful evening. You know, as being NAVSARI na thayne NAVSARI ma presentation hoy એટલે ઘણું સારું લાગે. So I'll definitely in next 30 minutes I'll make sure that we'll cover majority of the things in genetics. So I know sitting over here, they have started, you know, all of us have started our journey of cell phone from that Nokia, right? Nokia phone thi start karelu, then we started with camera phone, then smartphone, now iPhone. So similarly, you know, things has been changed in the field of genetics or in the field of medicines also. With the advancement of technologies, we are now able to detect, you know, so many things by using so many different platforms. But when we say genetics, it always causes a dilemma that which test to select for which patient and why. You know, that always causes a, you know, for a consultant to patients કે આમાં શું કરવું જોઈએ. So earlier, you know, we started with this karyotype. The, you know, just 15-20 years back, the only test for genetics was the karyotype. કંઈ પણ હોય તો શું કરી શકે, let us do karyotype. Then, you know, the fish came in the picture that gives, you know, more faster report. Then the advancement of PCR techniques, we will be able to detect, you know, some PCR-based, DNA-based testings. Then this QF-PCR came in picture. Then this microarray came in picture. Then sequencing-based technologies through which we are doing this NIPT or this pre-implantation genetic screening or diagnosis, endometrium receptivity analysis, inherited diseases, or these exomes and genome sequencing. So, you know, all these tests always, as I said, cause a lot of dilemma કે આમાંથી ક્યારે કયું કરાવું, karyotype or microarray, PCR or QF-PCR or FISH, exome, clinical exome, whole exome, what to do, કયા પેશન્ટને કઈ જરૂર છે. So I'll try to, you know, summarize this by giving case studies. Before that, I just like to say what genome is. Genome is like a book. You know, it stores all the informations for us. Whatever we are today is only because of this. You know, we have started our life from a tiny cell and we are an individual. What we are today is only because of our genome. That stored each and every information, physical, mental, everything. So the three-dimensional view of our genome is like, if we see from the top, it is the chromosome view, the karyotype, what we arrange books in a shelf, you know, by volume, by size, by like that. So when we arrange these chromosomes, it is our first dimensional, the top view of our genome. When we, you know, this microarray is a page view of our genome. When we, you know, start looking at the page, if is there any page missing, if is there any extra page is there, if is there any page which has been torn. So this is the microarray, this is the second view of our genome. And the sequencing is when we actually reading the book itself by, you know, word to word, a sentence to sentence, it is a sequencing. So this is the more deeper view of our genome. Now we have to select when we need to go with the chromosome view, when we require this page view, and when actually we need to read the line of our genome. So in a routine practice, you know, there are two types of patients came to us. One with no family history. The only thing is either they are suffering from missed abortion. So what to do in such kind of patients? So usually I follow this algorithm. જ્યારે કોઈ history નહીં હોય તો couple karyotype is the best tool. First to offer couple karyotype. If it is normal, then carrier screening or whole exome sequencing. If we found something, then definitely we can approach pre-implantation genetic diagnosis. Whatever you have found in the couple, same we can diagnose in the embryos. If POC is there, then definitely it is a use of, you know, doing test from the POC. And second kind of patients, they came with the history. અમારા ફેમિલીમાં આવું છે, મારા સિસ્ટરને આવું હતું, મારા માસીના દીકરાને આવું છે, કાકાને આવું હતું. So kind of that history they came up with us. What to do if index case is there, then definitely the choice of test start with is from the index case. analyzing the index, clinical findings, whatever is there, we can suggest them either with the karyotype or sequencing or PCR-based test, whatever is available. So let us start karyotype. This is the old but still the gold standard technique. Because, in couples, we are more interested to see whether they are the carrier of any balanced translocation or something like that, which is causing unbalanced event in the fetus. And that might be the reason of multiple missed abortion or not. Couple karyotype, here is the case which was abnormal. 31-year male patient was having a translocation between chromosome 5 and 7. We offered, 2 miscarriages was there. We offered them PGT for structural rearrangement. Only 2 embryos were there. Luckily, one was normal and one was having the same, there was a gain in chromosome 7 and loss in chromosome 5. So that means it was not normal. So they implanted the normal embryo and they delivered a normal child, healthy child. Now why, karyotype is so essential with microarray? So this is the couple. During their second missed abortion, they have sent the tissue to some other labs where microarray suggestive of trisomy 13. Third missed abortion, we received a sample of POC. As there was a report attached that in the second pregnancy it was trisomy 13, we counseled them for couple karyotype because we wanted to see whether what is exactly the reason for having a trisomy 13. Couple refused. We are absolutely normal. हमने तो कहीं ज नहीं तो हमारा माँ कोई खामी हो ही नहीं सके. Whatever you want to taste from the POC. Okay. So we advise for karyotype and microarray both. When we study the POC, we found that there was something present on the P arm of the chromosome 13. Sometimes happens in case of POC that the morphology is not good enough to identify what abnormality is there. So we reported an additional 13P and we advise now that there might be something wrong in the couple. And couple need to be investigated. Luckily, they agreed. And the female was a carrier, the mother was a carrier of chromosome 1322 translocation. So this is the case of trisomy 22. These 222 and the third one is attached here with chromosome 13. So if we have offered a microarray, in this case, definitely it would have detected it is a case of trisomy 22. But what exactly the cause which is causing every time this trisomy 13 or 22, that karyotype has ability to detect this balanced and unbalanced translocation. Can we CMA replace karyotype? I mean, can we offer CMA microarray test in couples? Anyone, you are offering couple microarray? If you are, then I'll say no, because here is a case, 9 years of marriage life, 4 missed abortion, 3 IVF cycles were failed, and couple microarray was absolutely normal. They came to us for counseling and advice for a karyotype. What we found, the female was having a balanced translocation between 2 chromosome 15. So it's a Robertsonian translocation with fusion of 2 chromosome 15. So in that case, the female is going to have only 2 types of eggs, one with 215, one without 15. So if these fertilize, it will be a trisomy of 15. If these fertilize, it will be a monosomy of 15. Both of the case, the fetus is not going to survive. So I mean, if they have relied on microarray, they perform 3 IVF cycles on the basis of microarray, that couples are absolutely normal. But when we perform the karyotype, we find that, I mean, there is no possibility that they can continue or they can have their own pregnancies because there is no chance of having a normal oocyte. So chromosomal microarray, when we need to have this microarray, it's a wonderful tool which can detect losses and gains. It is very useful when there is a congenital abnormalities or autism or developmental delays or mental retardations. So whenever what Dr. Jai has said, that when we find something in USG, whenever there is an abnormality is there, definitely we prefer microarray, but not in couples. So this is the case. Antenatal scan showed NT was very high, 6.4, absence of radius. The product of conception sample was received and advised for karyotype plus microarray. The karyotype was normal in this case, and in microarray we found that there was a loss in chromosome 1q of 236 kb. That was causing the loss of 11 genes and was causing this TAR syndrome. So now this is matching with what USG findings were and what the losses of genes has caused to the fetus. So couple karyotype was normal, next pregnancy CMA was normal, and they delivered a healthy child. So in these, in such cases we have to apply this chromosomal microarray. It is very useful tool. Whether every loss and gain in microarray they are useful. So this is the case where 27-year female, dual marker having a high risk, USG was absolutely normal. Amniocentesis done, CMA with QF-PCR done somewhere else, QF-PCR normal. CMA report says there was a loss in chromosome 18p region. But they have not mentioned which are the genes involved, whether it is pathogenic or not. On the basis of CMA, they terminate the pregnancy. Now looking forward to the deletion region, we process both karyotype and CMA from couple to check whether that deleted region was having any pathogenic genes or not. The karyotype was normal, female CMA was normal, and the male was having same deletion which they have found prenatally in the child. The 11p region, and same deletion we found 18p. So male was the carrier of this deletion. That means if with this deletion, the male is absolutely normal, that child might have no abnormalities, as USG was also normal. So not every deletion, not every gain is a pathogenic on which you can decide whether to, you can't terminate the pregnancy. So you have to see what exactly the genes are, what is the pathogenicity of the deleted or gain region is. So sometimes, we blindly follow in the era of this marketing, machines wala hoy, ke lab wala hoy, they promote like AOGA says that CMA is the first tire for, our test karavi joy, but it is not for couple. They have mentioned that whenever there is a congenital abnormality, USG ma tamne kai pan abnormality dekhai, then definitely CMA is your first choice of test. But do not apply it, or they are not saying you replace it with karyotype, right? So, microarray has its own advantage and limitations. Karyotype has its own advantage and limitations. Like karyotype can detect balanced, unbalanced event both, but microarray can detect only unbalanced events. So, that is the difference between karyotype and microarray. So this is the case, if we have done microarray, we might have missed this inversion Y in a couple. This is the case where there is, trisomy 22, but there is 21-22 translocation here. This is the case of inversion 9 in dysmorphic face, rocker bottom foot, inversion 9 was there. This is the case of derivative 21, trisomy 21, but translocation with chromosome number 2. This is the case of inversion 8 in a couple. This is the case of inversion 10. So, you can't replace any technology. Each and every test, they have their own advantage, they have their own limitation, but we have to, we have to choose कि सेमा कई जरूर है, and then we can give offer to the patient. So the best combination is either you choose karyotype with microarray. So what karyotype can detect, microarray जे detect नहीं करी सकते ये detect कर से, and whatever the microarray is not able to detect, karyotype can detect. So I always says that the combination of test is very essential. Do not rely only on a single test. Then use of these NGS technologies. What if couple karyotype is normal? So sometimes, majority of the time it happens that we offer couple karyotype and it comes normal. Now what next? Couple karyotype normal છે તો શું કરાવું? Microarray? No, never go for microarray in couples. Rather choose this carrier screening or these whole exome sequencing or clinical exome sequencing. This is the case of consanguineous marriage. Every time the fetus was having hydrops fetalis, the couple karyotype was normal. Fetal karyotype was normal, microarray was normal. We offer carrier screening, and what we found that both the husband and wife was carrier for this NEB gene. Just 10 days back, we have reported amnio from this couple by analyzing this NEB gene. It was normal, and they have now continued their third pregnancy. So this is the usefulness of this carrier screening. So whenever karyotype is normal, just don't go with the microarray. This is the second case where non-consanguineous marriage, 3-child with mental retardation, we offer carrier screening, and the female was having a deletion is SLC6A8 gene, which is on X chromosome. So this was the case of X-linked disease. So every male child was affected. Prenatal care, NIPT, nowadays everyone is asking for NIPT. So what exactly NIPT is? We use the maternal DNA and we use the fetal DNA which is circulating in the maternal bloodstream. We use that fetal DNA, we sequence that. It's a screening test. Always keep in mind that NIPT is NIPS, non-invasive prenatal screening test. It's not a diagnostic test, and whenever it comes positive, we have to, offer invasive testing for confirming these screening test reports. So, is it possible to screen surrogacy in NIPT? Yes. Twin pregnancy? Yes. Egg donor? Yes. Microdeletions, their sensitivity and specificity is less right now, but definitely future will come to that we can detect majority of microdeletions and monogenic disease by using NIPT. Keep in mind that it is not useful in case of multiple vanishing twins. Sometimes we received a call that just before 4 weeks one twin was fetal reduction was done, so can we use this NIPT? Technically, after 6 weeks, we can definitely do, but we don't encourage in case of fetal reduction, you go with the NIPT. So these are some factors which influence the results of fetal fraction. Gestational age, mosaicism, fetal aneuploidies, all these things which can impact the results of NIPT. There are some biological factors definitely affecting the NIPT, that maternal weight. Whenever the maternal weight is very high, then there is a chance of low fetal DNA. So in like mother's weight is 85-90 kg, and definitely in such cases we get a very less amount of fetal DNA. And to report NIPT, we require at least 3.5 to 4% of fetal DNA. That is what fetal fraction is. So whenever it is less than 3.5, we can't report NIPT. If mother is on heparin, low molecular weight heparin or any other medicine, definitely it causes low fetal fraction. So what test to perform when NIPT is positive? So you have opt NIPT comes with high risk. Now what test we have to select? So this is the case, first trimester was positive for trisomy 21. NIPT high risk for sex chromosome aneuploidy. The Z score was very high, 5.7. So amniocentesis was done, we received it, we advised for karyotype and fish. Fish was absolutely normal. So it was a dilemma that dual marker says it's a trisomy high risk for trisomy 21, and our NIPT says it's a sex chromosomal aneuploidy, and fish is absolutely normal. Neither trisomy 21 nor aneuploidy is in sex chromosome. As we were waiting for the karyotype report, we recheck our NIPT. We reprocess the sample and NIPT. It shows the similar results. High risk for sex chromosome. When we found the karyotype, it shows that it was an iso-X chromosome, which is the variant of Turner syndrome. In around 18% of Turner syndrome, this iso-X chromosome is present. So fish was normal because there was no trisomy 21. And here, we use a probe which is specific for centromere. So here there are 2 centromeres, so fish was absolutely normal. So if we have relied only on one test on fish, that is, it is normal, then we might have missed this ISO-X, which is a variant of Turner syndrome. Same thing was reported by other lab, like they have a high risk for trisomy 21, high risk Z score was 6. They performed fish and microarray. Microarray was absolutely normal. This is the limitation of microarray. And on fish, they found that the fetus was mosaic for trisomy 21. So sometimes these microarrays can't detect low-level mosaicism. So again, if they have relied on microarray report that it is normal, they might have missed it mosaic child with Down syndrome. So never rely only on single test. Whenever possible, always use a combination of test. So the second, family history. Family history hoy to su kari sakai. So this is the case, workup in index case whenever that is possible. This is the case, 6-year male, global developmental delay. Patient was from Canada. They have done karyotype in Canada. It was absolutely normal, couple karyotype, and the child was absolutely normal in karyotype. They came here for IVF for the second pregnancy. Looking forward to, we offer that it's a case of global developmental delay. Microarray would be a better choice instead of karyotype. So we offer them microarray as a pre-PGD workup. What we found that the child was having, luckily, they came with the child. So the index case was there, and the child was having a loss in chromosome 8 and gain in chromosome 12. So these indicates, and the regions was very big, more than 5 MB. So we were in dilemma that it is a case that can be picked up by karyotype also. So we were interested whether is there any balanced translocation in couple or not, but they were into so hurry that we want to finish our IVF cycle and we want to fly back to Canada. So they were even ready with these embryos and biopsies. So what we do, we use that child's DNA for PGD. We use that DNA as a PGD starting material, and we standardize our PGD LOD, limit of detection, whether this loss and gain we can detect with our own kit or not. Luckily, if we can detect this, you can see there is a blue dot gain, red dot that is loss. So definitely we will be able to pick up if is there any loss and gain between these chromosomes which was found in CMA. We received few embryos. One was showing this gain. So again, we doubt that definitely the father or mother might be the carrier of chromosome 8 and 12, but unfortunately karyotype was not possible. 2 embryos were normal, but in such case we can't differentiate whether it is normal or a carrier. If balanced translocation is there, because this shows everything is normal, it detects only if loss or gain is there. So there was no gain, no loss. So they transfer the embryo, but we advise for microarray to check whether, after, is there any possibilities that we might have missed and microarray can picked up. So when microarray can be used, this is another case, this child came to our lab, was having difficulty in walking. She was walking on toes, sitting, she was not able to sip through straw. She was sleeping with open eye. She was having difficulties in smiling. When she was smiling, her face was deviated to one side. So this was the features we found. Her CPK level was very high, so suggestive of muscular dystrophy. But her what could be the possibility? Either muscular dystrophy, Ulrich type, what was there? But DMD, BMD, SMA, everything was normal. At that time, microarray was not with us. This is a case of 2012. So we sent a sample to Delhi, Sir Gangaram, and we found that there was a deletion in TNXB gene. This is the region. So with some pathogenic genes were deleted. So we offer parents for the same test. Parents were absolutely normal. So it is a case of de novo deletion. In second pregnancy, CMA was normal and they delivered a normal male child. So this is the things we have to keep in mind, that if index case is there, definitely go with the index child. How much important DNA storage is. Sometimes DNA storage it is not that costly nowadays, or even you can store a DNA by just putting a drop of few bloods spot on a tissue paper, and they can store that DNA also. Nowadays technology એવી આવી ગઈ છે કે આપણે ટીશ્યુ માથી પણ DNA ના સ્પોટ માથી બ્લડ સ્પોટ માથી DNA એક્સટ્રેક્ટ કરી શકીએ છે. સો ઇફ તમારી પાસે એવી કોઈ નહીં હોય તો આવી રીતે પણ you can store the DNA. So this is the case, clinical history, a male born preterm, low birth weight, so many abnormalities were there. Further we came to know that the family history of DMD is also there. So from the stored DNA, luckily the DNA was stored from the first child. We performed whole exome sequencing and we found 3 mutations in 2 genes. One in this SBDS gene, which was present in father and mother both. So they were the carrier of these genes, and which was causing so many, Bardet syndrome, Joubert syndrome. In the second pregnancy, next pregnancy, we performed the exome sequencing, and again the child was having both the mutations. It was both heterozygous mutations were present, and they terminate the pregnancy. So in this case, neither index case nor DNA was there. Now what to do? Sometimes it happens that the index child પણ નહીં હોય, DNA પણ નહીં હોય, ફેમિલીમાં કોઈ હોય પણ it is not available for analysis. So what to do? On the basis of clinical history, family history, we can offer KT, microarray, NGS. In this case, like G1 severe ventriculomegaly, husband sister has polydactyly, husband uncle has same polydactyly. Microarray was normal from PSC, and lab utilized all the DNA. So neither DNA nor index case, nothing was available. So, after observing the clinical indications, we found that it could be a Joubert syndrome or a ciliopathies, and we offered them whole exome sequencing. We found 2 mutations from the, but wife, it was uncertain significance, but same was there in husband also. So while we were analyzing the report, couple already conceived naturally. So this exome sequencing takes around 1 month time. So when we called them for the report, they said that we are already having a pregnancy. So we asked them to wait for 14-week scan. Ventriculomegaly was there at 14-week scan. When fetus DNA was analyzed, was compound heterozygous for both the mutations which was present in the father and mother. So they terminated the pregnancy, and we offered them PGD or donor for next pregnancy. So take home message as, sir asked that, do you want something from us? Sir પૂછ્યું હતું કે તમને તો અમારા જીનેટિસિસ્ટ માટે હું તમને એટલું જ કહીશ કે અમારે શું જોઈએ, તો આપ મુझे ફિનોટાઇપ દો, मैं आपको जीनोटाइप दूंगा. So you just give me the information of phenotype, that is very essential, to correlate genotype phenotype correlation. Thank you from my DNA.
Thank you, Dr. Gaurav.
I request Dr. Kanchan Dadwe to please come forward and felicitate Dr. Gaurav Sastry.
And I would request Dr. Archana to felicitate them with bouquet. You have kept us alive. You have prevented audience from sleep. And it was so fluent. Yeah. It was so fluent. And the most important part was that this responsibility was chosen. So, thank you very much. And without you people, this program would not have been so live.
Hello. Before proceeding to AD, 2 announcements. One is Anaesthetics Obstetrics Association of India has organized national conference in September at Ahmedabad. So those who are interested can go to website and register themselves. Second is NBFM, that is now blocks of gas, that is gas of Shiv Sir is organized now blocks live demonstration on 2nd and 3rd December at Surat. So it is very nearby, you can take the advantage of live demonstration of now blocks. NBFM. Now coming to this AED, before that, just briefing that IRCF guidelines from 2017, IRCF, Indian Resuscitation Council Foundation, has given opportunity to all anesthetists to be a part of that and qualified for that, and you can give demonstration and you can certify this also. So just 5 steps are there. First step, safety. Safety of ourselves and safety of victims. Second, call for help. 108 or any hospital or anything like that. If 108, then 2-3 messages. One patient or more than one patient, your exact location, your exact name, and what you are doing to do before they reach. Third, COLS, that is compression only life support. In the morning I have given demo where at the G-post process, 2 finger up with the 2 hands, don't bend the elbow, give pressure to the fulcrum to the hip joint. 30, 30, 30 is counting, 30, 30, 5 steps are there. After that you assess the patient. Again, if there is no response, again give 5 cycles. Or if 2 persons are there, you can interchange. Now the role of AED is came. As soon as you receive the AED, the first choice is AED. You interrupt your count, just open the machine, and how its machine looks like this. These are the machines kept in the usually in the glass box in the airports or malls or most of the railway stations now, advanced railway stations. So this is one company's machine. Mostly they use select Philips machine or any other company's machines. So before that we have to see the patient. It will not work in asystole. Any defibrillator will not work in asystole. It works only in 2 conditions, as sir said, VTAC and VFAB. So mostly in Western world there is a conduction abnormalities more there. Our is a ischemic or coronary disease are more there. So before applying this, there are some instruments available in this cart. One is scissor to cut the cloth. In COLS or compression only life support or CPR, we don't have to undercloth the patients. But in this, if we want to apply this AED, we have to remove the cloths. So expose the cloths with the scissor is available. Mostly they contain the scissor and razor. If there is a hairy patient, we have to remove that hairs. If there is no razor, then they will supply with the 2 pads. So one pad we have to apply it and remove it just like a wax. And second pad will apply it for this functions. So here is this is a demo mode. So it is
Training mode. Call for help.
So see,
Follow instructions to apply pads.
so you have to remove the pad from his
Remove
back.
clothing from patient's chest. Locate pads package in back of AED.
बताओ से तो focus करे से बोलो.
Tear open pads package. Peel pads from blue liner. Apply pads to patient's bare chest as shown.
आप focus करो. Zoom करो.
Remove clothing from patient's chest. Locate pads package in back of AED. Tear open pads package.
It is training mode, so it is
Peel
repeat
pads
the
from
things.
blue liner. Apply pads to patient's bare chest as shown. Remove clothing from
So
patient's
after
chest.
applying the pads, it will analyze the rhythm. It automatically.
In back of AED.
It will analyze and say it is a soakable rhythm.
Tear open pads package.
Soak is advice. It will announce, soak is advice. Don't touch the patient. It will advise, and as we are ready, we are not touching the patients, we have to just press the button shock. So it will deliver the current according to its requirement. It usually from 50 to 150 joules. And again it will analyze the rhythm. There is no rhythm, then it will advise CPR. So only one way to restore rhythm is compression, only life support. If there is a VTEC and VF, then and then only it will work. Otherwise, only way to restore the rhythm is compression. Compression, only life support. So
Continue for 1 minute, 30 seconds.
this beep is a rate. We have to give the depth according to this rate only. Don't push fast, don't be slow.
Continue for 1 minute, 15 seconds.
So like that, we have to continue. If it is shockable rhythm, then it will shock. Otherwise, it will advise CPR. Now, many of our hospitals have this type of defibrillators.
For 1 minute.
From this, how can we made automatic mode? So just on the machine, this is biphasic. Sorry, this is monophasic, that is biphasic. Monophasic has more current of 50 joules. And it has specific pad, and we have to apply the pad to the patient. In automatic, just we have to apply, we don't have to hold the pads. So this is one kind of monophasic. It has 200 joules. That is started from 50 to 150. We can select the current from here also, if we want to decrease or increase. So if we press this synchronized mode, then it will be automatic automatic, just like it works as a automatic. If there is a QRS complex, and if it is shockable rhythm, then and then it will start giving the current. Otherwise, it will not work. So we can make this type of defibrillator to automated also. But the automated is readily available nowadays. So these are the usually outdated. Nowadays, no one is purchasing this type of, because of it is monophasic. So biphasic defibrillator is advised to take for your hospitals. These are the older modes, but it is also working. Nowadays, the dynamo technology defibrillators are also available. Battery-less. If you charge it, then it works. Otherwise, there is no battery. You can give the dynamo technology. You can charge itself, and it will deliver 2-3 currents at a time when there is battery is not working. So this is just defibrillator. We usually encounter this type of AED at many places, and we must know how to operate it. Just it is.
Suppose there is an arrest.
Yeah.
And heart stops.
Asystole. This doesn't work. It works only when there is a rhythm on shockable rhythm. Till previous years, we all learned that this will start the heart. It will not start.
Sir, now the question which I had before many years, sir, Dr. Gajjer sir, you have a VD, you have a patient. Now we have already said, and it is a fact that he doesn't work in asystole. What will you do? Will you shock or not shock?
CPR.
There is a patient, you don't know whether the patient has asystole because sometimes fibrillation you may not pick up clinically. You don't have ECG machine going on that patient's chest. So you don't know whether asystole or VFVT. You have a machine, you have a patient. What will you do?
Now, how you differentiate between asystole and ventricle? Yeah, that is why.
That is what I want everybody to know.
That is why.
Because having a machine and a patient does not serve the purpose.
See, when you have a cardiac arrest situation, first thing is assess the patient, shake and shout and start CPR and BLS and other things. And as soon as you get a defibrillator, apply pedals, check the rhythm. Basically, these quick look pedals are like ECG leads. The moment you put them on the chest, it assesses the rhythm and you see, is it a straight line, is it a VF or is it a VT? For that, you need to know what VT looks like, what VF looks like. So that is where your AED comes as a rescue. If you don't know anything, if you are a novice, you put that, it will do on its own. It will instruct you. But if you are a clinician with post MBBS, this thing that you know, okay, this is a VF, this is a VT, and you can give a shock, and then you resume CPR. Don't wait to check for rhythm, the pulsations. So as soon as you get a defib, you have a patient with cardiac arrest, check the rhythm. These are all quick look pedals. The moment you put the pedals on the chest, it will analyze the rhythm, and in case of AED, it will tell you it's a shockable rhythm, give shock. In case of this thing, you need to judge and you have to give a shock. So currently only biphasic defibrillators are available in the market, and if you are planning to buy a defibrillator for your hospital, buy a biphasic defibrillator with a ETCO2 port, because what we want is a high quality CPR. I was telling you CPR, CPCR, CPCSR. So when you're talking about CPR, CPCSR or CPCR, you need to give high quality chest compression. And one of the best modality of giving high quality chest compression is to assess the quality of chest compression when you're giving. And that can be assessed if you have an entitled carbon dioxide connected to the defibrillator when you're giving bag and mask ventilation. So that if you're achieving ETCO out of at least 10 to 12 or 10 to 15 millimeters of mercury with your bag and mask ventilation or endotracheal intubation, that means your chest compression is of good quality. And one of the earliest sign of reversal of spontaneous circulation is rising ETCO2. So if you are going to buy defib, buy defib with ETCO2 port. At a basic level, primary nursing home level, where you don't have clinicians, these are wonderful devices. AED is a wonderful device. Your device, you need to have it.
Now, coming the last.
Now the last step in our whole day's program. I hope you are enjoyed, enlightened with new knowledge. And before we go to high tea, the last formality, vote of thanks from the Secretary, City Branch.
Now, the last moment of this one-day live workshop, vote of thanks comes to hand of the Secretary. Before, in the February months, I met Sunl Pandya sir and decided to have this type of workshop in South Gujarat. And today is the final result of this. So thanks Sunl Pandya sir for his valuable time given to us and enlightened us with the very basic knowledge. And I'm sure that in day-to-day your practice, it will definitely your patient will be helpful. Your many things you were doing since long now maybe change from tomorrow. And thanks all pharma companies who have supported us. Thanks BR Farm, and especially thanks to Bhumika Dorajia, who is one of the owner of this BR Farm, and our member is also, she is also our members. So providing all these facilities at a cheap rate. And thanks our Dinesh Maharaj, who has done very good tasty foods for us. And now this pakoda, bhajiyas are there waiting for us. And of course, NOGS Foundation is there. That is a backbone of this, because usually we conduct one workshop in a year since since 2020, when I am still in secretary. There's now coming days, 4 or 5 days are remaining as a secretary. And we won the best city branch awards in Anaesthesia branch. That is the big achievement as a small branch and just 2 years from branch, and we have received that award in last year. So all possible because of my members' support, and of course this workshop is possible because of the NOGS Society, Gajjer sir, Styen sir, Vipul sir, and all the other members who has helped in completing this workshop. Thanks to all, and thanks MOC, today's MOC, both of them have done very fantastic works. And thank you all, and we proceed for the high tea.